Now we're going to talk about the process of chronic kidney disease. Some of the same concepts, but this is progressive, right? It's chronic. And what is it exactly? Well, it's defined as the presence of kidney damage or decreased GFR less than 60 milliliters a minute for 3 months, greater than 3 months. Everything okay? So 1 of every 9 Americans has CKD. It's a lot of people, right? So it's progressive, non-reversible loss of kidney function.
That doesn't necessarily mean you're on dialysis, right?
No, I mean, you can have chronic kidney and not be on dialysis yet.
Yeah. Okay.
But once their GFR gets low enough and they have enough toxins built up, they'll go on dialysis. %70 of people are unaware that they even have any kind of disease going on, disease process. Ignorance is not always bliss. I've taken care of people who worked their whole lives, didn't go to the doctor, and they're on dialysis because they had kidney disease. They had hypertension, and they just never treated it because they worked. Half the cases are diabetics, diabetes mellitus. So that's why we're always harping on the diabetics to be compliant, because we want to conserve their kidneys for as long as possible. And then 1/4 of cases are hypertension. CKD is much more common than acute kidney injury, right? Because it's a progressive disease. And, you know, we may see more and more of this, because people are living longer, right? And dialysis helps them live in longer. We do have an increased aging population, and the baby boomers and all. There's increased rates of obesity. What does obesity cause?
Hypertension.
Diabetes, metabolic syndrome, hypertension, all of that. But the kidneys are very, very adaptive. They can adapt. And I told y'all that they have this amazing ability, have all these nephrons that has all this the glomerulus, and so you can have partial damage, but the kidney's still working fine, so people don't even realize it. Because they're not going to go do a GFR on everybody. Not the specialized GFR. Because when you get blood work, it'll say you're greater than such as. It's just kind of an estimate. So to actually do a GFR, they have to do a special test. And they usually don't even do that unless you're high risk. So that's why a lot of people can live and not even realize they have it. Because the kidneys are amazing. So there's staging here. And again, this table is more or less a reference for you. Stage 1, where your GFR is greater than 90. So they have some damage, but they have a normal GFR. So these people are going to probably be on a special, watch your diet. Make sure you go to your doctor and do your checkups.
But that means you probably have an increased body creatinine, but you still have a
not necessarily.
How do you know it's kidney damage?
You don't. That's why it's so hard to detect. So only that. Because if you notice when you get your blood work, it doesn't say greater than 90. I think it says greater than 60.
Yeah, that's it. You're like.
Because it's just an estimate. So to get this really in tune, you have to do these tests. It's on page 1076. No, it's not there. But it's the special GFR test. There's different ways they do it. I forget where it's at, but it talks about it. It's just a good to know. It's not a need to know. But there is a place in your book that talks about GFR and the different calculated GFRs, the different names of them. But the reason they don't do it, they only do it on people that they suspect kidney disease. So that's why a lot of people don't even realize they have it, because it's not just a test they go do. So stage 2, it's just it's a progression. Your GFR gets lower and lower and lower till you get to a need for dialysis. Well, the reason why it's just showing you here that it's progressive. That's all you really need to know. You need to know what the level is for dialysis, right? Less than 15. That's important to know. And you just need to know that it's staged. Like it gets worse, worse, worse. Stage 5 dialysis, your GFR is less than 15. And again, that is table 46.6. Okay. So stage 1, say you've got someone, they've got their family history of kidney disease. So the doctor's like, I want to do a specialized test on you. I want to see what your GFR is. Well, say that they've confirmed they're in stage 1. Well, you're going to educate the patient, right? That's what the doctor's going to have you do. And that's what he's going to do if he's a good doctor. You're going to get some education. Decrease the risk. How do you preserve your kidneys for longer? How do you conserve them? That's what you're going to get. As far as and so as you can see, as it gets worse, you're thinking about, okay, you get your GFR gets a little bit lower, say it gets around 30 to 40. Well, your kidneys are not functioning as well, so you may see some problems. You may see some fluid buildup. You may have to be on a special diet. So just keep that in mind, that as it gets worse, you have to, it's a progressive disease, so you're going to have to follow diets, you're going to have to watch your fluid intake, that kind of thing. And then, I like this visual because as it gets, it shows you less than 15 is in the red over here, and that's your end stage disease. That's when you're end stage. That's when you're most likely going to have to go on dialysis. Normal is more than 60, so that's what we see when we get a test. When we get our blood work, it's just kind of an estimate. It says your GFR is good, it's greater than 60. But once you get these specialty tests, that's when they start giving you more specifics. So what do we see? Well, we know that there's damage. We know that we've already talked about the kidney, and we talked about how different parts of the kidney excrete, secrete, reabsorb all our fluid and all our electrolytes and our hormones. So what you will see varies depending on the stage you're in, and also the cause of the CKD, your age, your degree of compliance. Where are you taking your medicine? Where are you controlling your diabetes? Where are you controlling your blood pressure? So what you see is usually your degree of compliance with whatever problem you have. And amount of urine output. Are you still putting out good urine output, or has your kidneys, are you starting to show some buildup in your ankles, and you've got some swelling because your kidneys are not able to get rid of everything? So these clinical manifestations are a result of retained substances. You have a decreased filtration. Your BUN and creatinine will go up. You're going to see some fluid retention. So, as your GFR goes down, because what is GFR? Glomerular filtration rate. So it's how well your glomerulus is filtering. So as it goes down, it's not filtering as well. What's going to build up in the body, in the blood? Waste. So you're going to see some uremia. Uremia is just urea, which is like urine in the blood. It's very toxic to the different body systems. There's a lady on page 1077 that shows you everything. And we're going to cover signs and symptoms of uremia over these next slides. You may even see some polyuria as the kidneys lose the ability to concentrate the urine. Metabolically, the diabetics may require less insulin. You'll have an altered carbohydrate metabolism. Because if the kidneys aren't filtering and getting rid of the waste, they're not getting rid of the insulin either. So they may require less insulin. Then you may get this hyperinsulinemia. And when that happens, you get another problem. You get elevated triglycerides. Because you have altered lipid metabolism. And then electrolyte acid imbalance. Your sodium could be up, it could be down, or it could be normal. Again, back to our very first slide where it talked about what happens throughout the kidney. Well, it really depends on where the damage is. Is your sodium increased? Is it low? Because of impaired excretion. The sodium can cause hypertension, edema, CHF, the increase in sodium. You may see calcium and phosphorus alterations. We're going to talk more about that. But a lot of times we'll tell our patients to stay away from magnesium-based meds such as Milk of Mag, antacids with magnesium. You're going to see hyperkalemia. So it's the same kind of problems that we saw before because the kidneys are not doing their job. Metabolic hyperkalemia, so you might see an elevated T wave. Metabolic acidosis. Because of inability to excrete the acid load, right, your ammonia. Also, defective absorption, and then the regeneration of bicarb. It's defective. Your bicarb, remember I said the kidneys make it, they also reabsorb it. If there's problem with kidney with the filtration, then it's not able to do its job. So some of the same stuff we talked about before. What do you think chronic kidney patients die of? Heart disease. Cardiovascular disease. That's usually what they die from. All right, so I copied this girl over because I felt like it's important. Of course, you can imagine with any kind of waste buildup, of course you can get cerebral changes, right? The level of consciousness, all that good stuff, neurologic. I mean, it really affects every body system. Paresthesias, why do you think that is? What is that? Who can tell me what paresthesia is?
Numbness and tingling.
Numbness and tingling. Why do you think that's a thing?
Like diabetic neuropathy.
Right, neuropathy. The waste, right? Damaging blood vessels. So, basically, every system. Itching. They get uremic frost where they're itching. They'll the waste will come out of their skin and it'll be like a white crack, almost like, it's not necessarily a rash, it's just sitting up on top of the skin. It's white and a uremic frost. They can have breath. What's that called? Uremic fetor. Y'all heard of that?
Yeah.
And that's basically just the urine. It smells like, their breath will smell like urine. So just about, every system is affected. Urinous odor of the breath. That's under the gastrointestinal. So that the calcium builds up and can cause vascular and soft tissue calcifications. So these are just some clinical manifestations of CKD. So chronic. Most of the time, though, when you start seeing this, it's pretty progressive. It's pretty progressed. You're not going to see this in the beginning. So in the beginning, what you're doing, what the patient is, you're teaching the patient, is conservation therapy. You're teaching them, okay, follow your heart diet, follow your renal diet. You're doing all this to conserve the kidneys, to keep their GFR as high as possible. Well, when it gets to this state, their kidneys are not working very well because this waste is building up and it's causing other problems. It's causing these other problems. So we're going to talk about a few of them. Hematologic changes. We're going to have anemia. Who can tell me why we have anemia? The erythropoietin, right? We talked about that before. What does the kidneys do? What is it? Stimulate the release of the erythropoietin for the bone marrow to produce the red blood cells, right? Well, you have a decreased production of erythropoietin if the kidneys are not working properly. They can get bleeding tendencies because of impaired platelet aggregation. That's secondary to the waste buildup. The uremia affects one of the platelet factors, platelet factor 3. So the uremia can cause this. Increased infection and change in white blood cell function, and then a decreased inflammatory response. All right, so this is an important concept. The mechanism, CK, chronic kidney disease, with the bone mineral density loss. And I copied this from your book. So your GFR goes down. So when your GFR goes down, you have decreased phosphorus excretion. The kidneys can't get rid of it, right? So you're going to have an increased serum phosphorus. Well, on the other side there, you're also having, what do the kidneys do as far as activating vitamin D, right? So, you have a decreased activation of vitamin D. Therefore, you have impaired calcium absorption. So you're going to have a decreased serum calcium. So what eventually occurs is that your calcium is not in the bones where it's supposed to be. So you'll get osteomalacia. Calcium will build up in the blood. What does that cause? Vascular and soft tissue calcifications. They can even get what's called, that's my eyeball, a red eyeball. So I hope you remember it. A uremic red eye. Even your eyes get red and bloodshot because of the uremia, because of the calcium buildup. It causes irritation from the calcium deposits in the eye. So everybody understand that? It's not in the bones where it belongs?
So at first it's low and then it goes high. It's at the bottom it says high.
It's high in the blood.
Okay, but they both say serum.
It's low in the blood because your body can't pick it up. So because it's so low, parathyroid hormone takes it from the blood.
No, I get that, but they both say serum, so that's why it's like.
So what are we going to do to try to figure out what's going on with our patient? We're going to do a history and physical exam always. Might do a urine dipstick just to see if they've got protein, white blood cells. They may do an albumin to creatinine ratio. That just shows if the kidney's spilling protein. It shows you a little, like a better test than the dipstick. Of course, GFR. Okay. There used to be a table. Oh, there it is, yeah. Now, you don't have to know this, but it is a kidney. It talks about the kidney, the GFR. And the different tests underneath the Cockcroft-Gault formula and the MDRD study equation. So there's a couple of different ways they can figure the GFR.
We just need to know GFR.
You just need to know GFR. Renal ultrasound. This can detect any obstructions, anything like that, to determine the size of the kidney. A CT scan. And a kidney, renal biopsy. All of those are definitely tests. They can just, diagnostics to see what's going on with the patient. What are our goals? Well, our goals are to preserve the existing kidney function. If your patient has a GFR of 45, we want to keep it at 45 for as long as possible. Decrease the risk of cardiovascular disease. So we're going to give them medications, antihypertensives, statins, those kind of things to prevent further damage, right? We're going to provide comfort. So, as far as collaborative care, we're conserving the kidneys for as long as possible. There may be lifestyle changes, exercise. Initially, they may not be on a renal diet. They might just be on a DASH diet or a cardiac diet. And then as the kidney function deteriorates, they'll start putting them on a renal diet. Nutritional therapy, low potassium, low sodium. They may give them erythropoietin injections with iron supplements, calcium supplements and phosphate binders.
Why calcium supplement? I mean, yeah.
Well, it would depend. It really depends on if it's really patient specific. So someone that's got these problems, that's got the high calcium, low in the bones, high in the blood, they're going to be getting regular blood work. And it's really, as far as their nutrition goes, it's very, very specific to them. So, one person may be on calcium supplements, one person may not be. So it just really depends on what they need. So not everybody has got that, but a lot of people do. So they may or may not need the calcium supplement. Phosphate binders is another collaborative care. That's just binds to the phosphorus in the bowel, and they excrete it that way. That's usually near the end, like once they're on dialysis or right before they go on dialysis is when you're going to start seeing these problems. In the beginning, like when they're still got a pretty good GFR, they're just like me and you. I mean, they might have to follow a cardiac diet though. So you're conserving their kidneys in the beginning. You don't really see all these problems till later. Towards, as their GFR goes lower and you start seeing the increase in the waste, the uremia and things like that. Let's talk about drug therapy. Again, same thing. Polycystyrene sulfonate for your hyperkalemia, IV insulin, IV calcium gluconate. Always remember when you give insulin, you're going to give some glucose. Also, the other treatment is the Veltessa or the Patriumur. I don't know if I'm saying that right. They're hypertensive drugs, right? So what are some of those? ACEs, ARBs. And sometimes ACE inhibitors and ARBs are often given to diabetic patients and those with like the non-diabetic proteinuria because they decrease proteinuria and they can delay the progression of CKD, so that's why. But you may see someone on a calcium channel blocker or hydrochlorothiazide. So it's not always ACEs and ARBs, but those are good ones.
What does it say at the end of IV calcium gluconate?
That's that other medicine for hyperkalemia. It's PATRIOMER. That's the generic. Yeah. How do you say it, Marie? Patrioma. So, for someone with the CKD MBD, a bone mineral density problem, they may be on phosphate binders, calcium acetate, calcium carbonate. They bind with phosphorus in the bowel, and it has to be administered with meals. The dose is usually like 1 gram a day. And like I said, it's near the end. Once they're either about to go on dialysis or on dialysis. So kind of like end stage is when you're going to see a lot of this problem with the bone mineral density. To administer it with meals. And like I said, sometimes they will need the vitamin D supplement, like calcitrol. But for the calcitrol to work, your phosphate's got to be lower. So they still are kind of going hand in hand. So administer with meals. There's some meds in your book that talk about if someone has, if they don't need the calcium or they need calcium, there's phosphate binders that are more specific to that. Sevelamer. Often statins will be given just to lower your LDL and your triglycerides. So the statins is often a drug they'll be on. If myopathy develops, you know what's the side effect of statins? Sometimes can be myopathy, right? They can go into rhabdo. They can have sore legs and stuff. That's kind of when you know something's going on. If they're having some myopathy, then they can try maybe atorvastatin instead. It has less chance of that.
So atorvastatin has less likely chance of getting
Myopathy.
myopathy?
Less than the
Like
simvastatin. Simvastatin. That's kind of dark. So fibric acid derivatives also can be given. They're just a different type of, they help lower the triglycerides. So they kind of focus in on the triglycerides and they lower those. So fibric acid derivatives. And that is gemfibrozil, Lopid, Lopid. Lopid, Lopid, that's a fibric acid derivative. Gemfibrozil, Gemfibrozil. Oh, Z-I-L. So, we got all these drugs, right? And what do the kidneys do? A lot of times the kidneys, drugs are excreted by the kidneys, right?
No.
Some of them are. So, chronic kidney disease can cause decreased elimination of the drugs, and they can have potential drug toxicity. So, you have to also keep that in mind. Like digoxin. What are some other meds that you need to be careful with so your decongestants, antibiotics, because if they already have some kidney disease, the antibiotics are hard on the kidneys. NSAIDs or naproxen, all of those can be hard on the kidneys, so you have to be aware. Also, your decongestants, your antihistamines, what do? What do those do? They constrict, right? So you have to be careful. They can be nephrotoxic if you already have some kidney damage. I already talked to you about like the magnesium-based meds, aluminum-based meds. If there's kidney damage, it can accumulate in the body because it can't be excreted. there's a chart in your module that we're gonna fill in for your meds. We won't do that right now. We're gonna do it at the end, but so that'll help you kind of revisit your meds. But now we're just gonna go right into nutrition, and as you can tell, kidney disease has a lot to do with nutrition, as we've already talked about. There's a chart in your book. It's important. It talks about chronic kidney diseases, page 1082, 4610. And this is basically just that copied over. But as far as it goes, you want to think about protein. And it says it's individualized. Again, just like I said earlier, they usually will draw a person's blood and they'll decide, okay, can they handle a little more protein? Do we need to restrict protein? Because what is the byproduct of protein? Ammonia, right? So nitrogenous waste. So it can be individualized, but if you're trying to conserve the kidneys, they may put a little restriction on the protein, right? Because you don't want any nitrogenous waste. So that's why it says it's individualized. It really depends on the patient, their GFR. They're still doing a lot of studies on the protein because there's, I think, a place in your book that says they're not restricting it anymore, or they don't restrict it as much. But it can, it can be it can cause the waste to go up, the ammonia. So you do sometimes need to restrict it. And we'll talk more when we talk about dialysis, how it's not as restricted. They even have special protein drinks for someone that's got some kidney failure that can't process it. That will that'll give them some protein without the waste. So they still need the protein because what happens when you don't get the protein? Catabolism, right?
So then they have
Malnutrition.
DUA.
So all of this, again, is individualized. Why do you think we need to worry about potassium?
Because their body's not excreting it.
Right. The body's not excreting it, so they don't need to go eat a bunch of cantaloupe or baked potatoes. So there, another chart in your book, for 4611, page 1083. It's got all your high potassium foods.
So should they avoid this or just lessen the amount?
It's individualized, so most of the time they have to just watch what they eat. They they may be able to drink a half a cup of orange juice. They just can't drink a whole cup, They can't go eat a whole watermelon or a whole cantaloupe.
I'm reading this and it's funny because it's like they can't eat anything because they're also on a cardiac diet.
Right.
The cardiac diet has a lot of greens, and that says no greens.
Yep. They can have iceberg lettuce. They just can't have.
They can have
They
water.
can't have the good lettuce.
Snapper and ice chips.
They can have bread. They just can't have the good bread. They can have white bread.
And you gotta be careful. Milk.
Now they can have the dairy because
Milk?
they just have to take their phosphorus binders, right?
It says milk, 1
Yeah,
cup
it
there.
says yogurt in here too.
Yeah, they just have to be careful. Because why do you think they can't? What do you think is in the yogurt? A lot of times the fruit is, so they have to be careful. And it depends on how the yogurt's processed.
Chocolate.
So they have to be careful. Cantaloupe, avocado.
Quart of avocado. Keep that in mind. 1 quart. Maybe Dad take it whole avocado.
So potassium's a big deal. They have to avoid high-risk foods. I got the wrong page number.
I've had my patients return their trays.
Because they knew.
Yeah, we have preset meals that are delivered, and they're on a renal diet, and I've had patients be like, they're going to kill me. They've given the pineapple, bananas throughout the day. He's like, I can't eat any of this.
Wow. Again, phosphate restriction, so they're going to be on their binders. So if they're taking their binders, a lot of times they can have the dairy. But they just have to make sure that they take their phosphorus binders or calcium carbonate with their food. And then sodium, of course, that's individualized as well. But most patients, to conserve the kidneys, hypertension or cardiac diet is to watch your sodium, right? So, why do you think they need to avoid salt substitutes? Because they have potassium. It has potassium in it. So, they need to avoid salt substitutes. They can have Mrs. Dash. They can. I think Mrs. Dash is salt-free. And they're making more and more things that they can have. It's becoming, again, when you have a big part of the population that has this, they're going to come out with more and more stuff. So let's talk about water restriction. So everybody is not going to be on a water restriction, especially in the beginning. A lot of times it depends on the intake, depends on their urine output. So as their kidneys eventually stop working, sometimes they'll not put out anything. Sometimes they'll put out a little bit. It's really individualized, but again, it depends on their output as far as how much they can take in. Same formula. You want to consider your insensible losses when you're figuring it up, right? So whatever their output is, you have to add 600. You will see that again, so I'd make sure I knew how to do that. You take their output, you add your 600. That's how much they can have. It's 24 hours, so the next day they can have that much. As far as nursing management, again, family history is a big deal. Their history is a big deal. Their habits, their comorbidities. Do they have hypertension and diabetes? What are their medicines, the current and their past prescription medicines? And motivation for these people is vital. They say that there's an art to nursing. It's a science and an art. Well, motivating people, getting people to follow their diet. I mean, yeah, you do create trust, you establish trust, but sometimes it is an art to get people motivated to follow their diet. But motivation is vital. And when it comes down to it, we can teach, we can motivate, but it really has to be their decision. So you have to somehow figure out how to make them, kind of buy into it. But prevention and conservation, right? That's the big prevention, preventing your GFR from getting worse. If it's already 45, conserving it, that it won't get any worse. Drug and diet compliance. Do they take their medicines like they're supposed to? Do they follow their diet? Those are things that are vital. Avoid NSAIDs, decongestants. Like we talked about, the pseudoephedrine and the phenylephrine, they both can cause vasoconstriction. So they may have to avoid NSAIDs, avoid the decongestants, the aluminum and mag-based laxatives and antacids. Nephrotoxic drugs such as gentamicin, vancomycin, the streptomycin. And then they have to make sure they're aware of like some people take herbs, so they gotta look into those and make sure they're not causing any problems. So herbal preps, might need to avoid them. Let's talk about some nursing diagnoses. Excessive fluid volume related to impaired kidney function, related to compromised regulatory mechanisms, risk for electrolyte imbalance, related to impaired kidney function, results in hyperkalemia, hyperphosphatemia, imbalanced nutrition, less than the body requirements, right? Because they can't eat anything. Nausea, vomiting, anorexia. You may need that. Okay. Everybody have that? All right. So, as far as implementation, we're implementing health promotion, regular checkups, strict adherence, conservation, home care, daily weights, blood pressure checks, so teaching them how to check their blood pressure. Signs and symptoms of fluid overload. What do they need to look for? Do they need to look for swelling in their feet? Crackles? What do they need to look for hyperkalemia? I had a patient one time tell me that he was a dialysis patient, and that in between his dialysis days, he decided to just go on a binge of eating a lot of fruit and melons. And his potassium got up so high that he was completely paralyzed. And luckily someone found him, but his potassium was like 7. And they got him some help, and he lived. But yeah, sometimes they go, they can get a little non-compliant, and there might be a holiday, and they eat a lot of watermelon on 4th of July or something like that. So we have to make sure that they know what to watch for. So when conservative therapy is no longer effective, they're going to go on dialysis. So often, when their GFR, gets less than 15, and they have the accumulation of all these uremia, so the problems that the uremia causes, and their GFR is less than 15, they may or may not have some fluid building up. They probably will. But then they need to go on dialysis. And they can go on hemodialysis or peritoneal dialysis or even transplant. They can go on the transplant list if they're compliant. We'll talk more about that when we talk about transplant. The patient and the family need clear expectations and support. If the family's not supportive of the patient's diet, of the patient's fluid restrictions, then the patient's not going to be successful. So this is one of those things where you got to get the family on board as well. And then you got to think about too their comorbidities. Are their comorbidities controlled? Do we need to make sure, you know, that we have a closer watch on their blood sugars, that kind of thing. You know, I talked about hypertension, but also diabetes is a big deal. So that's got to be closely monitored and controlled. Now, evaluation. Again, did we do the right thing? Are we helping them to be successful? So, evaluating, are our fluid and electrolytes within normal limits? Are they at an acceptable weight? Not underweight, not overweight. A lot of people, when they'll have a weight loss because, of course, you know, they sometimes with the buildup of the toxins and then the inability to eat as much protein, like I said, they will have some muscle wasting and all. So a lot of patients will have some weight loss. So the key is a balance, you know, an acceptable weight with a less than 10% weight loss, and are their comorbidities controlled? And that is all of this. I know it's a